All right. Good evening, everyone. My name is Julie Creech, and I will be your moderator for tonight's edition of the AMSSM National Fellows Online Education Committee Lecture Series. This evening, we are going to learn about abdominal visceral trauma from Dr. Korin Hudson. But before we get started and before the introductions, let me go ahead and kind of lay out the ground rules as normal. So again, tonight's lecture is presented by the National Fellows Online Lecture Series and sponsored by the AMSSM. The kind of goals for tonight would be to serve as an adjunct to your individual program's educational programming, provide direct access to educational experiences with very experienced AMSSM members and expert guests who are going to be presenting, and assist with your preparation for CAQ. Our rules of engagement, we ask that during tonight's lecture, you mute your microphone and turn off your video. If questions arise during the presentation, please feel free to share those in the chat function. And if you'd like to include your name and your program, you're welcome to do that. I'll then ask the questions to Dr. Hudson at the end of her presentation, at which time you can also live submit as well. And then after the program, please complete the evaluation so we can continue to improve these lectures. So now I'd like to have the opportunity to introduce Dr. Korin Hudson. She is an associate professor at Georgetown University and practices sports medicine and emergency medicine with MedStar Health in Washington, D.C. and in Northern Virginia. She is currently the program director of the MedStar Washington Hospital Center Georgetown Sports Medicine Fellowship Program. She received her undergraduate degree and medical degrees from the University of Virginia and remained at UVA for her residency training in emergency medicine before she went on to complete a fellowship in primary care sports medicine at Georgetown University and MedStar Washington Hospital Center. Dr. Hudson has been on faculty at MedStar Georgetown University Hospital since 2006. She has served as a team physician for Georgetown University Athletics since 2009 and is also a team physician for the Washington Wizards and a consulting physician for the Washington Capitals. Dr. Hudson also serves on the Big East Conference Health and Safety Committee and the NCAA Division I Concussion Safety Protocol Committee. She's actively involved in research and is currently conducting ongoing research on concussion, emergency action planning and response, and emergency response simulation and education. So it is without further ado that I will let Dr. Hudson take over and give us a wonderful lecture.
Thank you so much. Here's always the drama part where we make sure that I can share the screen and we get to where we want to go. Does that work? You got it?
This looks great.
All right, so if you can see what I'm seeing. So hi, everybody. Nice to be here. Thank you all so much for having me. So we're going to talk a little bit about abdominal trauma and athletics today. We'll start by saying, oh, there we go. I have no relevant financial conflicts. We always got to start there. I always say I'm looking for some if anybody has any to offer. So our playbook for today, we're going to talk about some relevant anatomy as it pertains. We'll talk about some common injuries, how we perform a rapid evaluation and examination as it pertains to our athletes. We're going to talk about the role for ultrasound in the assessment of these injuries, and then how we put it all together. And I'll throw in some pearls here about how I think this does pertain to the CAQ and where I think this comes in. I think there are a few kind of buzzwords in some places where you can get some good pearls here. When we talk about the anatomy here, remember we talked about the abdominal wall, which we'll talk about first, the musculature and the structure of the abdominal wall. GU, which is really kind of a separate topic, the genitourinary system comes in later. There'll be a little bit on that here. Solid organs, we'll talk about the liver, the kidneys, the spleen, pancreas, which we really won't touch on much here, the retroperitoneal organs, including the kidney, the hollow organs. And Julie, as I'm looking at this, I'm realizing I think we are in an old version of the talk. We're going to roll with it anyway. And then the hollow organs, including the small bowel and the large bowel. Abdominal wall. Oh, I'm wondering if I really do want to roll with this. I don't. We're gonna have to go with a different version. I'm gonna unshare for just a second, guys. Hold on. I uploaded 2 versions of this talk and I uploaded the wrong one. Hold on. You don't want this one. You want the new version. I'm so sorry. We ran with a little problem here where I had to switch from one computer to the other, and in doing so, I ended up with the wrong version of the talk. Hold on. I'm so sorry. Oh, Julie, do you have the version that you had? That may actually be better. I hate to do this, but
I do. Yeah.
it may be better to do it from your version than from mine.
Okay. Yeah, that's no problem. Let me get it pulled up.
Because I feel like the version that I'm doing is one version old and doesn't have a lot of changes that I think are actually pretty relevant here.
How does that look?
Good. Let's go with it. We're gonna make it go. All right. So we're gonna get up to. There we go. We're gonna do this on the fly, guys. Thanks. All right. So we're gonna go on to the next one here. We're gonna start with the abdominal wall. So when we talk about abdominal wall injuries, we talk about contusions to the abdominal wall. We're going to talk about diaphragmatic injuries. We'll talk about some rectus sheath hematomas, muscular injuries, including things like hip pointers, just a little bit, and then other soft tissue injuries. So if you roll ahead. So muscular contusions, our mechanism here is like a direct blow to the abdomen, direct blow to the abdominal wall. We talk about intramuscular and subcutaneous bleeding. This is really just a bruise, right? Typical bruise. Presenting symptoms will be pain, swelling, tenderness at the site, a little ecchymosis that you can see under the skin, maybe not immediately, but pretty quickly. Evaluation is pretty easy, right? This is going to be a physical exam. Imaging typically not required. If you have a bedside ultrasound and want to take a quick look, you can sort of see how far deep this goes. Make sure it's not into the deep layers. Make sure it doesn't go below the fascial layers. Treatment is really symptom-based. Ice, analgesics. You can consider some additional padding and think about return to play. This really shouldn't affect the athlete in terms of having any peritoneal signs, right? If they have any peritoneal signs, if they're having any deep tenderness on palpation, you really need to think again of whether this is just in the muscular layers. Right, next sign. Diaphragmatic injury, I think we've all seen collisions like this. We see this sign, we know that at least two of those three guys are not getting up off the grass. There's going to be a little moment where everybody takes a deep breath and we're going to kind of pause to see who's going to take a moment. Really, everybody's getting the wind knocked out of them in this. That's that diaphragmatic muscle spasm. There's sort of a transient sense of doom. Everybody takes a deep gasp. No one's quite sure what's happening next. Really, the evaluation here is focused on ruling out other serious injuries. We got to take a minute and make sure nothing else is hurt, shake off the cobwebs, make sure that nothing else more serious is going on. Really, there's usually no treatment required. Once you make sure that there's no significant trauma, make sure there's no ongoing tenderness, make sure everybody's getting up and walking around. The condition is self-limited. Return to play can be permitted as soon as the athlete is able. And really, again, they usually tell you that this is the case. They're breathing fine. They're not having any pain. They say, "Doc, I'm good to go. Get me back out there." This is just a temporary spasm of the diaphragm. That classic, I got the wind knocked out of me. Go ahead. Abdominal wall hematomas are something that can be a little bit more serious. You can get a rectus sheath hematoma that can be caused by a rupture of the epigastric artery or vein, or sometimes both. Or you can get lateral wall, which is much more rare, which can be either a slow venous bleed or sometimes a rapid or arterial bleed, usually coming from a deep circumflex artery branch. These sometimes can result in significant bleeding. These are usually a result of direct trauma. The more significant bleeds usually happen in people who are on anticoagulants, though I've seen this a time or two in athletes who obviously were not on anticoagulants, or we probably wouldn't have had them playing contact or collision sports, and can just be that odd hit that just happens in such a way that causes this big hematoma to collect. The key here is that they'll get a really obvious kind of grapefruit-sized or large swelling. You can feel the hematoma. It feels deep to the muscular layers. They can still contract the muscle over top of the muscle layers, and you can sort of feel that hematoma underneath. Again, if you've got bedside ultrasound, you can see that in the layers. But really, the key here is CT with IV contrast. Sometimes if you do a CT or a CTA with IV contrast, you can see active extravasation from the bleeding vessel. Some sites will like MRA or MRI to actually rule out other injury. And the key here is you want to make sure that this is extraperitoneal. You want to make sure that there's no intra-abdominal injury, that all of the injury is in fact in the abdominal wall. If you advance that one, we can actually see one of these. This is a rectus sheath hematoma. Again, you can see that large sort of egg-shaped or lenticular blood collection in the abdominal wall there. But it's really all extraperitoneal. This is all in the abdominal wall itself. As we advance one more, we'll talk about the management here. Again, this is typically conservative management. In the smaller hematomas, ice, analgesics, gradual return to play. You can consider padding the site. In some cases, if there's ongoing bleeding or oozing, we might consider angiography, or which maybe go on with or without embolization to stop the bleeding. And in some cases, we might even think about surgical options to evacuate that hematoma. Because these surgeries don't need to go in through the peritoneal fascia, we can do this all extra abdominally. That hematoma can be removed in a way that actually the recovery time is quite short. We just lift up the muscle layers, remove the hematoma, get the muscle layers back down. Again, it's not like a speedy recovery, but it's not like intra-abdominal surgery, 6 to 8 weeks. The biggest complication there is a post-op seroma. And so you do have to keep some compression on those layers for some time. So again, there is some recovery time, but it's not like a major intra-abdominal surgery in terms of recovery. Splenic injuries, I think we worry about splenic injuries a lot. They're not common, but I think if we think about all intra-abdominal injuries together, there are at least a couple of large case series which show that about 10% of all significant intra-abdominal injuries come from sporting injuries. And of those, most of those are injuries to the liver and the spleen. Blunt trauma to the left upper quadrant or the left lower thorax is the most common mechanism. This certainly comes mostly from collision and contact sports. As we see more extreme sports, motocross, some of the certainly the aerial sports are risky for this. I work with a group, we have a sports medicine group that takes care of the jockeys at one of our racetracks. And we certainly know that this is an injury that we could see in our jockeys as they get thrown from horses racing at speed as well. Certainly more common in athletes with a history of recent mono, and we'll talk about that a little bit in a minute. But the key here is to know that splenic lacerations can be life-threatening, right? So of all the things we talk about in sports, most of the injuries we discuss, we have a little bit of time to think about it. We have a little time to talk about it. We have a little bit of time to, quite frankly, get it wrong once or twice, to consult a friend, to look it up, to think about it a time or two. Splenic injuries are not one of those. These can be life-threatening if we get it wrong, if we second guess ourselves. So we got to get it right. We got to get it right the first time. So if you see trauma to the left upper quadrant, or an athlete who looks like they've had an injury to the left upper quadrant and you're concerned, pay attention to those hairs on the back of your neck and that sinking feeling. Next slide. So again, these presenting symptoms may be left upper quadrant pain, might be flank pain. Kerr sign is nonspecific, but it's that referred pain to the left shoulder that comes from diaphragmatic irritation from free intraperitoneal blood. It's sort of classic for a splenic rupture, but really that's intraperitoneal blood, usually described in a supine patient as that blood touches the diaphragm, that diaphragmatic irritation causes shoulder pain, but it's not necessarily specific for the spleen or specific for that left shoulder. Shown here on the slide are Cullen's sign, that periumbilical ecchymosis, or Gray-Turner sign, that flank ecchymosis. Again, those are nonspecific signs for intraperitoneal blood. On exam, you're going to see left upper quadrant tenderness to palpation, hypotension and tachycardia, which are things that we'd like to think about as a splenic laceration or splenic rupture, are really late signs or may only be present to just a fraction of patients. Remember that a splenic laceration is often encapsulated. It's often really held inside the spleen for quite some time until that laceration is quite severe. And so the spleen can hold quite a bit of blood inside. It may take a while before we actually get to true hypotension. And many of our athletes, especially our adolescents, may maintain, they may compensate quite some time before they become tachycardic. So don't wait for them to become hypotensive or tachycardic. It may be way too late. Next slide. So without going way into ATLS, if you suspect a splenic injury, get them to the ER and get them to the ER fast. Call an ambulance. Once they get to us in the ER, they're going to get 2 large bore IVs and labs. They'll get imaging. If they're in a trauma center, they'll probably get that FAST scan, which we'll talk about, that ultrasound in the ER, but they'll probably go pretty quickly for a CT with IV contrast. they may go directly to the OR based on a positive FAST scan if they're in a trauma center. They'll get monitored with serial H&H, hemoglobin, and hematocrit. There's a grading system that we don't need to go into here, but just know that there's a grading system based on severity. And typically, if we can avoid removing the spleen, or the trauma surgeons can avoid removing the spleen, they will do that. Most adults can avoid splenectomy for most injuries. The goal is to keep them calm, quiet, not moving a whole lot, and repeat imaging in just a few days. If they're unstable, though, they may require splenectomy or ligation of those splenic vessels that are bleeding. If they do have a splenectomy, remember that they should be vaccinated against those encapsulating organisms, the Haemophilus, the pneumococcal organisms, the meningococcal organisms, and then they have a really slow return to play. If they've had a non-operative recovery, that return to play is 2 to 6 months, and 2 is really aggressive. They probably shouldn't even consider return to play for at least 3 months, so 3 to 6. For some very elite athletes, they may opt for splenectomy because the operative return to play really gets down as low as about 6 to 8 weeks, right? Once they've had that surgery, it's a post-surgical recovery because you're now not worried about that secondary splenic injury. The spleen is out. So that may actually slant you in some cases towards a splenectomy, though you really need to think about the risks and benefits of that and the sort of complications that may come from having a splenic patient long-term. And really what that means for your patient. So weigh that really carefully. I know there have certainly been some discussions like that in certain very, very high level athletes. All right, next slide. So here's a picture, the coronal image on the screen right, patient's left, obviously there's a picture of the spleen with a big laceration through it. All right, and we'll move on and we'll talk about some liver. Oh, sorry, we got more pictures of spleen. So spleen, there's sort of a pictogram on our left here that shows some free fluid. We'll talk about what the ultrasound pictures look like of this, but shows the spleen there and the kidney with a dark layer of fluid. Thank you, Julie, for being my mouse in between. A dark layer of free fluid in between at the splenorenal interface. And then on our screen right, the spleen there is just floating in a giant hematoma of blood there. That's a huge spleen that's about to probably come out. All right, next we'll talk about some mono. So infectious mononucleosis, EBV and CMV, classic clinical triad, fever, pharyngitis, lymphadenopathy. I think we're all pretty well checked out on the diagnosis of mononucleosis. Our classic clinical teaching that we should not consider return to contact sports before 21 days. And I will tell you, I practiced this way for years. Until Jill Sylvester from the Air Force and came through our military fellowship, our consortium fellowship in DC here many years ago. Jill did this great study with her colleagues in 2019, military case series. They looked at 826 cases of mono. And in their study, only 74% of their splenic injuries happened within 21 days. About 90% happened within 31 days, but that showed that there was a significant proportion of their injuries which happened between that 3rd and 4th week. So that's actually been practice changing for me. That actually has made me counsel my athletes a little bit differently, especially when going back to contact or collision sports, about the risk associated with that 3-week return versus that 4-week return. I think I've really changed the way I counsel athletes in terms of considering that 4th week, unless I'm thinking about really low risk sports, track or something, tennis, something that's really relatively low risk. Or if we have a better sense that maybe they had symptoms for an extra week. Remember that imaging is really not helpful in that return to play decision. A lot of people want to say, let's ultrasound the spleen, let's CAT scan the spleen, let's say it's normal size. That's really not helpful in making that decision. All right, let's talk about the liver now. We are going to talk about the liver. So remember that the liver can be injured again in blunt trauma, right upper quadrant trauma, also penetrating, but that's usually not our mechanism here. Again, it can also be fatal if unrecognized or untreated. Our presenting symptoms will be similar to the spleen, but on the other side, abdominal pain may refer to the right shoulder or the shoulder blade, may have nausea and vomiting. In fact, a lot of hepatic injury patients will have nausea and vomiting. On exam, we're going to have right upper quadrant tenderness. Again, that tenderness may give you kind of a Murphy's sign, like a gallbladder. They may take that sort of gaspy deep breath as you try to palpate that right upper quadrant. They may have that pain that refers to the shoulder blade or to the shoulder. There may be ecchymosis, or again, that peritonitis has signs of hemoperitoneum. And again, the hypotension and tachycardia may be late. Remember that hepatomegaly here, just like mononucleosis increases the size of the spleen, which makes it increase the risk of rupture, hepatomegaly is going to increase the risk of injury here, increase the risk of liver injury. So obesity, hepatitis, alcohol, certain other drugs and toxins and autoimmune diseases, which increase the size of our liver, also increase the risk of liver injury when we suffer trauma. So we think about those things and how they may impact. If you've got somebody who's got a palpable liver when you do their PPE, and they're going to be participating in a contact or collision sports, maybe think about whether they need a little extra protection or padding. All right, next slide. Again, ATLS, kind of how we manage these. If you think someone's got a liver injury, send them fast, send them early, especially if you're far from help or far from a trauma center. Again, there's a grading system that we don't really need to go into for the sake of the CAQ or for the sake of this lecture. About 80% of cases will resolve with observation. Unlike the spleen, we can't just take it out. So we have to really do everything we can not to operate on the liver. Livers don't really like to be operated on. They just bleed and bleed more and bleed more. But if the patient is unstable, sometimes they do have to go in and do some surgical exploration to achieve hemostasis, or sometimes some IR guided procedures to embolize whatever's bleeding. Often a repeat CT scan is done in 5 to 7 days to confirm that there's been no progression of the injury. And there can be complications, including bylomas, hepatic abscesses. These sometimes need to be drained, so secondary procedures are often needed, which again can prolong that return to play, prolong that recovery. This return to play really needs to be individualized, and we're talking months and months of return to play after hepatic injury. So again, these are rare in our usual Olympic sports, our usual high school sports and college sports. But if you're working, covering extreme sports, motor sports, equestrian sports, these are things you certainly may see. All right, moving on, some pictures of hepatic injuries. Again, we'll see some more ultrasounds in a little bit, but that's the edge of the lung there, screen left in that upper left picture, and the edge of the liver. And again, dark fluid there in between. Little arrow sign put in there by my ultrasound buddies who like to give us arrows to make things pretty. And then on the right, we've got a giant hematoma there off the edge of what is really a gigantic liver. All right, moving on. All right, hollow organ injuries. So these are really rare, but there are a couple, and included on the reference list, there are a couple of case reports here that I thought were worth including. Often with direct lower deceleration mechanism, and I think these are worth including because you have to just remember the zebra, because they're not so rare that you won't see one. And if you don't remember to think of it, you're not going to think of it when it happens to you. So remember this one when you see pain out of proportion or when the exam just doesn't fit. So this the case here with this picture was actually at a football game. This was actually a spectator in the stands who took a ball to the abdomen. There was a case that was presented at the AMSSM meeting several years ago, which was actually a football player who kind of had a clothesline injury in the middle of the game, came out just before halftime, lots of pain, some nausea, diaphoretic, just looked awful, but had a pretty benign exam, a soft belly, no ecchymosis. This patient presented similarly. And that's kind of the key. These patients look like they feel awful. They appear toxic, but their exam's really benign. It's soft, it's not rigid. They're in pain, but they're not really more tender on exam than they are. Again, pain out of proportion. They may or may not have free air on an abdominal x-ray, because the amount of air that's escaped from the perforated small bowel is really a tiny amount. CT is better if you can get some oral contrast in, but if you see the little bubbles of air there are tiny. In this case, you could actually see them on the case that was presented at ACSM. There were no free air bubbles, but when they did they actually had to do delayed imaging about 6 hours later and saw some stranding. They actually saw some leakage of bowel contents that was actually causing some stranding and inflammation. Ultrasound in these cases will be negative. It's not helpful because there's no free fluid and no leakage of fluid. So these are cases where you just have to have an index of suspicion and know that when something's not looking right, you just have to keep looking, keep going. All right. Renal injuries, I said we weren't going to do too much of the GU system, but I will throw in a little bit about renal injuries. Just remember the direct blow to the flank, especially in collision sports, can cause a renal injury. Usually these are self-limited. Very rarely do they require a nephrectomy. Symptoms are usually flank pain. You'll sometimes see some ecchymosis, hematuria. A patient comes in or an athlete tells you that they're seeing blood in their urine. Certainly be concerned. They tell you their urine looks dark, be concerned. If you're concerned about a renal injury, though, you might actually have to do a dipstick because the hematuria might be microscopic. If you're really concerned that you've got a renal injury, they may need a renal ultrasound or a 3-phase CT or an IV urogram. I've never ordered a urogram unless a urologist actually asked me for one. The 3-phase CT is a dry CT, and then a 90-second IV contrast CT, and then a 5 to 15-minute delay CT. So it gets different phases of the renal parenchyma, so they can actually look. One is actually a renal mass phase, which probably doesn't affect us in this point, and the other one kind of shows us the ureter and the bladder better. Again, there's a grading scale for the renal injuries, and in most cases, we're going to be looking at sort of the grade 1s and 2s. Those usually resolve in 24 to 48 hours. Once the hematuria has resolved, we can start a gradual return to play. Think about maybe some padding if you're worried about them getting hit in that area again. Much has been written about the athlete with a solitary kidney, and whether they should be allowed to play contact or collision sports. Again, very, very, very few cases of renal injuries that have required nephrectomy. So this is usually considered to be a risk-benefit discussion to be had with the athlete, with their parents. In many cases, there are the congenital solitary kidney patients who don't know that they only have one kidney until they're imaged for some other reason. So I think that in some cases you won't know that. There are some athletes, my nephew only has one kidney. He had a Wilms tumor when he was a baby, so he knows he had one taken out. And that's a discussion that my sister and her husband have with coaches as he's playing sports growing up. He's only 8, so these are not a lot of conversations they've had, but it's something that they've certainly thought about. So that's a discussion you'll want to have in terms of risks and benefits with athletes and their parents as they go. All right. I talked a little bit about horses. So this is one where you might imagine that both the jockeys and the horses might have renal injuries, right? So think about renal trauma. In this case, I will tell you actually, everybody was okay. Both the horses and the jockeys were okay in this case. The horse that's currently on the ground did actually then kick the guy in the number 1 horse, that jockey who's currently mounted, kicked him in the jaw. So the only real injury out of this was that the guy who's currently mounted on the horse ended up with a fractured jaw. But otherwise, everybody turned out okay. But you could imagine with trauma like this, you could end up with a liver, a spleen, a kidney, a thoracolumbar fracture, and who knows what else. So these are the kind of things that I think about. GU injuries are altogether a topic for another lecture, but I will throw in a couple little pearls here. That when we talk about trauma, blood at the urethral meatus is bad. Don't ever put a Foley in somebody who has blood at the urethral meatus. That's just a pearl of trauma wisdom. And the answer is always retrograde urethrogram. That's never the answer in real life. We don't do those anymore, but on the CAQ or any test question, if the words blood at the urethral meatus is in the question, the answer is retrograde urethrogram. So file that away someplace. All acute and traumatic testicular and scrotal pain should be evaluated with an ultrasound. So I don't care what the question says. If there's acute and traumatic testicular or scrotal pain, the answer is an ultrasound. And then just a practical thing. If you think a testicle is twisted, untwist it. Untwist it immediately. Don't wait for help. Don't phone a friend. If you think there's testicular torsion, detorse the testicle. And the way to think about that I was taught was open the book, right? So think about there being like you're holding a book and you open the book. And it's not half a twist, it's multiple twists. We see these in the ER probably 2 or 3 a year. And they detorse and you just kind of have to have a shock and awe moment with the patient and say, you're going to really not like me for the next 30 seconds and then we're going to be friends again. And if you think the testicle is twisted, detorse it. Don't wait for the ultrasound. Don't wait for the urologist. Save the testicle. All right, that's all I have to say about GU injuries. All right, now we're going to talk a little bit about ultrasound because who doesn't love ultrasound? The FAST exam, the Focused Assessment of Sonography and Trauma, and the E stands for extended. So the idea is that intraperitoneal organs lead to hemoperitoneum. We've talked a little bit about that, and that the blood goes to predictable locations with gravity. So as you lay down the supine patient, the blood goes with gravity to the supine portions, dependent portions, and that blood is fluid, right? We've all been doing ultrasound this year as part of our fellowships and training. We know that fluid is dark, easily detectable on ultrasound, and that we're really good at finding fluid on ultrasound. So it's a great screening test for that. And so we'll go forwards one and we'll talk about where we find it. So I've got 5 spots here. We'll talk about where we find, but the places where fluid likes to go. We've got the right upper quadrant at Morrison's pouch, or the hepatorenal junction. We have the left upper quadrant at the splenorenal junction, or the lienorenal junction. We've got the right and left pericolic gutters, which you could look at too. That's not really part of the FAST exam, but you can always go along the pericolic gutters. The pelvic cul-de-sac, or the pouch of Douglas, is another place. So right behind the bladder. So again, all the places where blood would settle with gravity, it's where the fluid goes. All right, so how much can you see? So minimum detectable on ultrasound is somewhere between 200 and call it 500 or 600 cc's of blood. And how much blood depends on like where you're looking, how fast it's bleeding, how good you are at finding it on ultrasound, and then how the position is patient, how the patient is positioned. CT can see a little bit less than that, so between 100 and 250 cc's of free fluid or blood. So it's a little bit more sensitive. And if you're ancient like me, when trauma and trained in ATLS, 2 decades ago, when we did DPL, so diagnostic peritoneal lavages, the way we used to do this was they would teach us to actually open the fascia with a little 1 cc nick. We'd actually cut down to the abdominal peritoneal fascia. We would take a liter of saline and lavage the peritoneum, and then we would drain all that fluid back out, and then we would send off that fluid, or we would look at that fluid, just hold it up to a piece of paper and hold it up to the light to see whether or not there was blood in the fluid. But then we actually had to violate the peritoneum to evaluate it, which in the end turned out to not be a really good thing for a lot of people. But it was very sensitive. We could see basically as little as 20 cc's of blood by doing this. But ultimately, ultrasound's a pretty good screening test for this. So let's talk about how we do the test. So actually, let's talk about the limitations. So what can we not see? So we can't see things when there's sub-Q air, right? So if there's any sub-Q air, so if we've got like a pneumothorax or we've got sub-Q air in the chest, we're not going to see well. You've got big gastric distension, right? So air is the enemy here. Gastric distension is going to be in the way. Patients who have a large body habitus, so a lot of sub-Q fat, can be hard to penetrate the ultrasound to get it down into the abdominal cavity. Operator dependent, right? Like all things, right? It's not like putting somebody through the CT scanner and we're just going to see the images that can come up. We actually have to obtain our own images. And then we're not going to have great views of the bowel. So we talked about those duodenal injuries. We're not going to see those very well. Hard to see the diaphragm. And we really don't get any good view of the retroperitoneal space. So if there's any kidney injuries, if we're looking about retroperitoneal injuries, we're worried about bleeds back there, we're really not going to get a great view of that space. All right, so CAT scan. Why don't we just get CAT scans on everybody? Well, it's great, sensitive and specific. They can see those hollow viscous injuries, can see the retroperitoneum, non-invasive, but time consuming. Right? Patients got to go to the hospital. They're expensive, need contrast. So like we've got this kind of pro and con here, like what are we going to do? So I think that there's times for CT, there's time when it's the right thing to do. But if we can do a quick screening test with the ultrasound, sometimes that's really helpful too. Sometimes we end up doing both and that's okay. But I think that there are times when we can do one or the other and we can make a good choice. All right. This is the slide I keep thinking was coming up next. So we've got our clinical picture, right? That's how we start all of our exams. We think, what do we think is going on? What am I worried about? And then there are 5 key views that we do as part of the extended FAST exam. The sub-xiphoid view, the right upper quadrant view, the left upper quadrant view, the suprapubic view, and then the extended view, which is the lung views. That's the E part. So we're going to go through each of these and we're going to look at some pictures of each. All right, so this is the sub-xiphoid view. So this is probably one of the harder ones to get because you really got to take the probe, and I'll kind of demonstrate on myself. You got to kind of really cram it under the xiphoid process. When you do this in the supine patient, it really almost has to be flat to the patient, right? So it's really going to be almost parallel with the patient and pushing, like pointing towards the manubrium. And really, it doesn't matter if you get a great 2-chamber or 4-chamber view of the heart. Sometimes you will on some patients, sometimes you won't. You're going to be using the liver tip as kind of an acoustic window here. But really what you're looking for is you're looking for a pericardial effusion, right? We're really just looking at that pericardium to see if we've got a pericardial effusion. That's what the black outline here is on that left-hand picture, right? So you can see there, we're outlining the pericardium. And if you see, it's the same picture there, right and left. And you can see there's really no fluid. And on the next picture, we'll show you some that have fluid. So see the difference? So in the last one, there was really no fluid there. This one, we've got some fluid around the heart. These are easier to see when you do on some patients. So next time you've got your co-fellows or you've got some residents around that you can kind of cajole somebody into letting you look at their heart. Do this a little bit and take some views, and it's easier to see on dynamic view when you can see the heart beating. Just get a look around the heart and see. You can see here we've got a pretty marked effusion here. We've got about 1 centimeter of fluid all the way around. All right, next view, I think we've got one more. Yeah, there's one more. So here you can actually see we get a pretty good view of the heart. We get almost all 4 chambers there, and you can see we've got a pretty good sized pericardial effusion going all the way around. All right, right upper quadrant view. I think the key here is we call this the right upper quadrant view, but you can see by the pictogram in that lower corner, really what you're doing is you're taking the probe and you're going almost all the way down to the bed. So you're going in almost the mid-axillary line and taking the probe almost all the way down parallel to the stretcher. And what you're looking for is you're going to look for that hepatorenal interface, and we'll show you what that looks like on the next slide. But if I see any mistake here, it's people start too anteriorly, and they end up looking at the gallbladder and they can't find the kidney. So if you do anything, start almost at the stretcher and move from posterior to anterior, and you'll have more success finding this view. All right, so let's show you what the normal one looks like. So this one shaded in on the left shows you left-hand side liver, right-hand side kidney. And then if you look at this, you can kind of see the echo texture of the normal liver there, normal kidney. Those should abut each other. They should come right up to each other and kind of kiss each other right there in the middle with zero fluid in between. No layer of fluid in between. The next couple pictures will show you some abnormal. So there you go. You see just a sliver of the liver on the left, and then the kidney there in the middle of the picture, and a big little lake of fluid. All that black fluid is abnormal there. So free fluid there in between, AB normal. We can't say that's blood. In fact, if you ever work with patients who have ascites, I will say Georgetown is like one of the liver transplant capitals of the East Coast. So we see a lot of patients with ascites. Patients with ascites are excellent to practice your FAST exam on because the free fluid of ascites looks just like hemoperitoneum. So they're excellent to practice on if you ever have an opportunity. All right, next one, we have another. This one's much more subtle. You see, again, that normal echo texture of the liver there taking up most of our image there on the left. We've got the kidney on the right and just a sliver of free fluid marked there with that blue arrow in between. I think we have one more. Here we go. Again, big liver up top on the left, kidney down low in the middle, and just a skosh of fluid in between. And again, even just that little bit of fluid is enough to tell us that there's free fluid in the belly. That shouldn't be there. Again, with the right clinical picture, that's enough to tell us that there's free fluid and we need to do something about that. All right, I think we have, oh, wait, one more. Okay, again, free fluid there between the liver and the kidney. Can kind of look like anything. All right. Suprapubic view. If you've done any OB ultrasound, this is just like you would go looking for heart tones in a first trimester patient or an early second trimester patient. You're going to go well below the umbilicus and point towards the pubic bone. And we're going to look for the bladder. A full bladder certainly gives you a good sonographic window because we're going to be looking behind the bladder for that free fluid. All right, so the next view shows us again bladder. If you've got a female patient, we'll see the bladder and then the uterus, and then where that black arrow or the black curvilinear line is on the left picture is where we're looking for free fluid. The picture on the right is showing us a normal, so there's no free fluid. We're looking at bladder, round uterus in the middle, and no free fluid behind it. Normal picture. All right, so this one, we've got a little bow tie of fluid, little curve of fluid on the left and the right. Male patient here, no uterus, or a female whose uterus has been taken out, I suppose. And the next picture, again, bladder, little bowel gas behind, giving us some scatter there, but we've got some free fluid there just to the left of the bladder. All right. And one more here. That's a little bit of fluid there behind the bladder again. All right. The left upper quadrant view, very much like the right upper quadrant, you want to put the probe almost in the mid-axillary line, go down again to the stretcher, and then I move from posterior to anterior. Again, I think if there's one error to be made here, it's to think of the left upper quadrant as if it's an anterior abdominal view. It's really not. It's really almost posterior. And we're looking for that splenorenal interface. We'll go ahead one and we can see, again, it's going to look kind of like this. It's hard to get a really good view of the spleen and kidney together, but the kidney will look much like it did on the other side. So this is normal with the spleen kind of hugging up against the kidney. Again, there should be just no fluid in between those two. In this one, I really look for that kidney first. You'll get that you'll see the calyces, and then look for the spleen to touch it. And then we'll see some abnormals. This one's hard to see the kidney, but if you see the bright white line of the diaphragm and you see the spleen and the ecotexture of the spleen, finding that black fluid, which in this case we'll assume is blood, but all we really know is that it's free fluid. You see that free fluid around the spleen is abnormal, even though we don't really have a good view of the kidney in this picture. And the next one, we get a little hint of the kidney in that lower right-hand corner, but again, we've got that tip of the spleen just floating in free fluid there. So even again, without a great view of the kidney, we've got a spleen that's just kind of floating in free fluid, which is bad. Next view, this one, we've got a better view of the kidney there in the lower right. We've got the spleen, and then really just a trace of free fluid up there, just under the diaphragm. But again, that's enough to get us concerned. And then the enhanced views, there are a couple here. Check above the diaphragm. We're going to look for hemothorax, pneumothorax. Really doesn't replace chest X-ray, but this is kind of a good screening tool again. And I'll tell a little story here that I also suggest that you can check the suprapubic view for pregnancy or for ectopic. Remember that you can have ruptured ectopic as another non-traumatic reason to have free fluid in your belly or to have abdominal pain. I will point out, and I've done this once, I'm going to let my error not be your error. You can do that entire FAST exam and scan your way all the way around a late trimester pregnancy in somebody who is obese enough to hide a late trimester pregnancy. Because you get all the way to the suprapubic view and you see bladder and a very heterogeneous thing in the uterus that looks like a heterogeneous thing that could be a fibroid, which is really a baby's brain if you are zoomed in way too far to see a biparietal diameter. Because you go all the way around the whole body of the fetus, right? Because you're way up in the corners and you're way up at the sub-xiphoid and you're way down low. So I will say I went all the way around to, not a late trimester, but I went all the way around a second trimester baby once. So don't do that. If somebody might be pregnant, please scan around the parts that might be pregnant. And then think about if you see free fluid in the belly of a reproductive age female, think about the possibility that there could be a ruptured ectopic pregnancy as well, in addition to any other traumatic causes, because that certainly can be life-threatening as well. All right, let's talk about the enhanced portion here. So in that view where we saw here, where we were just up under the clavicle, we are looking at sort of two rib spaces here. What we're doing is sort of look at the second and the third, and the third and the fourth, looking sort of in this orientation here. And what we're going to look is that we're going to look at the pleural line. And what we're looking at is the layers of the pleura as they slide against each other. And as we're looking at the layers, what you see, they call it beads on a string or ants marching, but you'll actually see movement as those layers of pleura slide against each other. And once you've seen it once, you know exactly what it looks like, but you won't see that if there's a pneumothorax because the pleura is gone, right? If one layer of pleura has pulled away from the other, then you won't have those two layers sliding against each other. So that's what you're doing. Find the rib, find the pleura, and see. This is an easy one to practice with somebody in clinic. All you got to do is, find a rib and look. So that's one. And then once you find that, you can switch it over into M mode and use your imagination. Once you put it into mode. So they call this waves crashing on the seashore, that view on the left, if it's normal, right? So the top part would be the waves, see the waves, and the bottom part is the sand, seashore. That's normal. If you have a pneumothorax, you don't get normal. Once you put it into M mode, you get what they call the barcode sign or the stratosphere sign. All you get is waves, right? So just lines, 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 no sand. So I say if you see the normal, you see enough normals, you'll recognize when it's abnormal. So anytime you get that, you can do some scanning on people when you're doing belly scans or anything else or any other part. I think this is a great one if you're doing shoulders. If you're doing somebody's shoulder, an ultrasound in clinic, go ahead and look at their lung because it's one extra view. It's an easy one to do. Just see the normals a couple of times. And then it's easy to recognize the abnormal when you see them. All right, so that's pneumothorax. Hemothorax, this is kind of down in that spleen and kidney again. Remember when we saw the diaphragm earlier? So we've got in the right picture, you've got spleen, kidney, you've got the diaphragm kind of arcing in between, and then we've got free fluid, but now the free fluid is above. So remember, we see that splenorenal interface, and they're really up, tucked tight to each other. That free fluid is not between the spleen and the kidney and the diaphragm. Those are all tucked in tight. Now the free fluid is above the diaphragm. It's now up above. So that's now a hemothorax. It's not hemoperitoneum. So think about which side of the diaphragm the blood is on when you're looking at that left upper quadrant view. All right. This is pleural fluid again. So we couldn't really, that wasn't fair of me to say that was a hemothorax. That was really fluid in the chest. We can say it's pleural fluid. I can't say it's blood. You can just say it's free fluid. Again, same thing here. And then we'll move on. All right, so pediatric FAST exam. Cute picture of one of my children, and I'm embarrassed to say I don't remember which one it is because at that age they look the same. God, that's bad. Okay, so what we will say about the pediatric FAST exam is it's not as sensitive. The studies show that the pediatric exam is sensitive somewhere ranging between 30 to 80%, which is to say, nah, right? So recognize that somewhere around a third of kids with solid organ injuries won't have hemoperitoneum, which means that solid organ injury stays encapsulated within the organ itself, which means you may not actually see free fluid. If it's positive, it's positive, right? The specificity is still really good. It's just not as sensitive. So if you've got little kids especially, and you're worried, the ultrasound is fine if it's positive, but it's negative and your index of suspicion is high, you still probably want to go ahead and get them to a hospital and get them scanned, probably with a CT, even though we like to avoid the radiation if we can. All right. So abdominal injuries are common, though severe abdominal injuries are pretty rare. I think that knowing the difference means we got to pay really close attention. We got to have a high index of suspicion. We got to be good with exam skills. If you're not thinking about splenic injuries, if you're not thinking about hepatic injuries, you're not thinking about those retroperitoneal injuries, you're never going to diagnose them. I think the EFAST exam is easy. It's non-invasive. It's a great screening test. It's not the be-all, end-all. It doesn't alleviate the need for ERs in hospitals entirely, but I think it can give us some reassurance. It can help us out a lot. And it certainly can confirm our suspicions when we're worried and help move us towards making the right decisions. Remember that no free fluid does not mean no injury. It just means no free fluid right now. If you're worried, be worried and definitely do the right thing. So I think from there, we'll throw out to any questions.
That was wonderful. Thank you very much.
Thank you for helping.
Of course. I enjoy being your Vanna. So I loved your comment on pre-participation exams, doing that abdominal exam and checking for hepatomegaly, and then potentially offering preventative padding in order to prevent injury. But that also kind of wondering, do you routinely recommend, and if so, in what situations would you recommend padding once an athlete is safe to return to play in someone who has had a splenic or a hepatic injury?
I think that that's a tough one, right? Because I think that there's probably not a lot of there's probably no data, right? And I think that I think when I've looked at this recently, most of the case series are old. Everything sort of says these big ranges of return to play and how we get back into exercise and activity. There's no literature or data specifically on what kind of padding is right. I think it depends on the sport a lot. I think it depends on the athlete and their position and their comfort. I certainly have some athletes who love padding for their various injuries and have wanted that after surgery or after trauma. I have some that absolutely hate it and would and take it off no matter what we put on them. But I've certainly worked with a lot of different athletic trainers and equipment folks to try to come up with strategies that I think make everybody feel a little bit more comfortable about getting an athlete out there. I think number one is trying to figure out what is the goal, right? I think the goal is to minimize the extension or worsening of a current injury, to minimize the risk of recurrent injury, and to decrease pain and discomfort. And then I think sort of last is to increase athlete confidence so that they feel more comfortable about being out there. I think if we're worried about extending the current injury, they probably shouldn't be out there if we're talking about abdominal trauma, right? So if that's our reason for going out there and padding it up, maybe we should rethink whether they're going. Maybe ditto if we're worried about recurrent injury, right? So if they've got a splenic injury and I'm worried that they're going to have a recurrent splenic injury, it's probably too soon for them to be going out on the field, right? But that's something we could talk about, but probably too soon. If it's an abdominal hematoma, right, or a bruise, a contusion, and we're worried about making it worse or recurrent, then maybe some padding makes sense. If it's for athlete comfort or confidence, I think there's a lot of new products out there that make this really possible. Some of the shirts and jerseys with the high density foam in it and padding. I think there are a lot of products out there that make that really possible now. And I think that the big reason I always try to ask myself, though, what are we doing this for and what's our reasoning? And then does that reasoning make sense? Am I doing it for the right reason? And then if I am doing it for the right reason, okay, now how do we do it?
Yeah, I think that's a really good point. Not to get them back soon because we want them to play and prevent them from worsening injury we know isn't ready to go prime time, but giving them that confidence that they can play because they are healthy. Another question that came up in the chat is not necessarily trauma related, but is abdominal viscera related, and just whether or not you have any recommendations for return to play after an athlete has had an appendectomy or a cholecystectomy.
Yeah, I think those are really good questions. And I think it really depends on the, well, it's a really qualified, it depends. It depends on the athlete, depends on the sport, depends on the surgeon and the approach. So I think that with many of the new minimally invasive approaches to these surgeries, a lot of the new appendectomies are being done laparoscopically with just like 2 ports now. And if one of the ports is umbilical, that's really pretty nice. Now, I will say a lot of our surgeons now are actually treating appendicitis with antibiotics. And so at least are postponing appendectomy to a time at which it is more convenient. And so at least for a handful of our athletes, we've had the opportunity to in season treat with antibiotics and postpone appendectomy to postseason, which has actually been kind of a game changer. And they've offered the same during COVID, actually, the very beginning of COVID, they did the same. American College of Surgeons recommended the same for cholecystectomy. They started treating acute cholecystitis with antibiotics as well, which was kind of a game changer because it started making the same option for cholecystitis as well. This idea that we could treat with antibiotics maybe and postpone surgery to a time when it's more convenient. So I think that's opened some new doors. I think that though, if it's done laparoscopically, you're really in the probably still the several week range because you have to worry about the risk of, I mean, the biggest risk is going to be that you're going to end up with some kind of hernia
at even the port sites. And the last thing you want is an athlete with an abdominal hernia or an umbilical hernia at any of their port sites. So I think work with your surgeons to kind of come up with a timing plan, and then talk to them about your sort of planning for approach, and could they use an approach and a scope approach that might, especially for your sport and for your athlete, maximize their return to play options and minimize the time.
Wonderful. Another question would be, if you have a negative FAST exam on an athlete who is you're either evaluating in the locker room or on the sideline, would that give you enough reassurance that you would decide not to send them to the emergency department for low to moderate suspicion of a bleed?
That's a really good question. And I think that all comes down to sort of pretest probability, right? So how big was my suspicion that made me ultrasound them? I admit that as, and it totally depends on where I hate being the person who keeps answering, it depends, right? So I'm the person who like has my butterfly, and I keep my butterfly ultrasound on the sideline with me, right? So I'm pretty likely to pull it out and ultrasound things just because I can. So it takes a pretty low bar for me to decide to ultrasound somebody at halftime, because I can. Also, it depends on kind of where I am. So if I'm covering like Georgetown football, I have the upside of knowing that our ER is 700 yards up the hill, right? So if I make the decision not to send them, and that's the wrong decision, I can like reverse that decision and get up the hill in 4.5 minutes, right? That's really different if I make that decision and I am 6 counties away in the middle of nowhere on a dark and stormy night, right? So I think it kind of depends on, did I do that ultrasound because I was really concerned because it was that guy who fell off the horse, right? If I'm at the racetrack and it's that guy who got like trampled on by the horse, the jockey who weighs 111 pounds and the 1,200-pound horse ran over him at 40 miles an hour, and he's pale and diaphoretic and hypotensive and tachycardic and clutching his spleen, and I ultrasound that, and he goes, and it looks okay, and he's still pale and diaphoretic and tachycardic and clutching his spleen, I'm probably still going to send him to the hospital, right? That's a little different than if I just pull out the ultrasound because I think it's cute and I want to show somebody something because I think I can find the splenorenal interface, right? So it kind of depends on the pretest probability.
Great. Those are all of the questions that we have in the chat, and we are at technically time, but if anyone else has any other questions, or if you have any kind of final parting thoughts or takeaway points, we appreciate it.
No, glad to have everybody here. I think that this is one of those things that just love to have people thinking about. I think that, again, we think a lot about the musculoskeletal stuff, and I think that one of the things that I see Matt Sedgley on here, Matt and I do emergency action planning together. And one of the things that Matt and I talk a lot about is sort of the game planning you do on the sidelines. Is that like the more you can sit and think to yourself when covering a game or a race or whatever, what would I do if? Like, what would I do right now if somebody had an MI? What would I do right now if somebody, you know, had a aortic dissection, which we didn't talk about, not usually traumatic, but I think we think a lot about what would I do if somebody had an open fracture? What would I do if somebody had a cervical spine injury? But sort of throw some of these, what would I do if somebody had a kidney injury into the mix? Because I think some of those are ones we don't think about all the time. And they'll kind of test you a little bit to think about how would I manage that if, you know, if that was what was going on.
Perfect. Andy, I don't know if we are going to do a post presentation survey, but Dr. Hudson, I just want to thank you for your excellent presentation and your time tonight. But I know that I learned a lot, and I appreciate all that you did.
All right. Thank you, everybody. Thanks you guys for having me.
Take care.